Right, hi everyone. I'm just going to give us another 5 minutes for everyone to join. Sorry about that. Yeah, so I'm going to give us another 5 minutes for everyone to join, and then we'll go ahead and start. Okay, so we'll go ahead and start. So thank you all for joining us today, and welcome back to another session on the Mind the Bleep urology webinars. So today's topic is going to be covering hematuria in all its details. I'll go ahead and just switch over to the next slide before we start. Yeah, so I'm just going to give a quick message out to our sponsors who we've partnered with. So that's CPD.me. They're basically providing us with hundreds of CPD accredited webinars. So they have an awesome application which you can find on Android and your Apple phones, with a cool drag and drop feature for your continued professional development. And it's mainly designed for people who are either registered with the GMC, with the NMC, or any other healthcare professional, really. So we've got quite a good discount from them. So 50% off. You can get their application for only £8 for the whole year. So if you're interested in that, please go ahead and use the QR code on the slides. And then I'll go ahead and hand over to Ahmed, who's going to be presenting today.
Hi, good evening, everyone. My name is Ahmad Alaqqad. I'm one of the urology trainees in Wessex, currently working in Haematuria Hospital Foundation Trust. Thank you, Zakaria, for inviting me to give this talk tonight. I hope that you are able to hear me loud and clear, everyone. All through, please feel free to ask. I believe there is a chat function that you can ask questions, and Zakaria will hopefully help us get these questions through. So we're going to use some questions through the presentation just to try to make it more interactive. So please do open on the website mentimeter.com so that you can answer the questions all through the slides. So without delay, what is hematuria? So, basically it's blood in the urine, and according to the American Urology Association, any 3 or more red blood cells in the high power field on microscopic evaluation should be considered a hematuria, and that what we call is a microscopic hematuria. However, there is always the gross hematuria, which is the other end, which means that the patient is basically seeing blood in the urine. So that is self-explanatory, more or less. So just to give you an overview, it's a very common in urology to see gross hematuria, and it presents more than 20% of the patients coming for evaluation. Looking at microscopic hematuria, even healthy adults can have it. So a lot of studies has been done to evaluate that, and some of them found as low as 2.4, but some of them found up to 30% of the healthy people can have microscopic hematuria. So not every microscopic hematuria means disease, and that's why it needs sometimes to be investigated, taking into consideration the risks that the patient have. Okay, so what I'm going to do today to make it a bit more fun, because I know listening 8 p.m. is not a lot of fun to someone talking about chest hematuria. So I'm going to try to make it an interactive and make you think a bit by making it a scenario, and then taking this scenario and just go through with it, into which I hope that you will be able to see how we diagnose UTIs, manage hematuria, and bladder cancer at the end of this seminar. So our presentation is Mr. Adamson, who's a 60-year-old mechanical engineer who presented to his GP complaining of visible blood in his urine over the past 2 days. He has been passing urine more frequently than usual over the same period of time, and it stings when he passes urine. He also had similar blood in the urine previously, about 4 weeks ago. Sorry, the slide just got stuck there. Yeah, so it's there. So he had a similar presentation with just blood about a few weeks ago, and at that time he didn't have any other trouble passing urine. He had a urine dipstick done by his GP, which was positive for nitrate, leukocytes, and red blood cells. He takes a number of medications, but the alarming medication is warfarin for his atrial fibrillation. So his urine dipstick is positive for nitrite, leukocytes, and red blood cells. Do you think this is significant? And why do you think this is significant? Do you think the GP needs to do any further tests? And what further tests are they, what they're going to show, and what treatment would be necessary? So if you all can open menti.com and put the codes just at the top and tell us, what do you think? Can you blame the hematuria on the combination of UTI and warfarin therapy? Do you think the cause of the hematuria is just the infection, what seems to be like an infection, and warfarin therapy, or not? So I'm going to give you a minute or two just to open the website, as this is the first question. And I hope some answers will come through. Anybody?
Okay, it seems like we're having a bit of an issue with Mentimeter at the moment.
Okay, I'll pass this question then. If you all try to log in into menti.com, and we'll try it with the next question again. Is that okay, Zakaria?
Yeah, that's fine. Okay.
Okay, can you help me to switch to the next slide, please?
Mm-hmm.
Okay, so the dipstick results are, as we've said, the presence of nitrate on the dipsticks means that there is an infection. So yes, the MSU is significant. So there is a UTI. Significant numbers of leukocytes and red blood cells can also be seen in an infection. And the GP should send an MSU to confirm the diagnosis and assess bacterial sensitivities. So the GP's job is to confirm that there is an infection. He can start treatment right away, but before that, he needs to have an MSU sent, because the MSU shows us the type of bacteria that is there and what type of antibiotics it would be sensitive for. So we need to have that before starting the patients on antibiotics, because if you start them on antibiotics before doing that, then we won't have the sensitivities that we need to treat the patient appropriately if he doesn't respond to the primary antibiotic that we've given. So MSU midstream urine, and it's usually carried as microscopy culture and sensitivity. It takes about 48 hours, and that's what I've said, why I've said that the patient can be started on antibiotics so that his symptoms obviously improves. We don't have to wait for this. However, this is very important in case that the bacteria that the patient has is resistant, and so that we can have some targeted treatment for the patient. So always make sure to actually send an MSU for any patient that you suspect an infection in his urine dipstick. So positive nitrite and leukocytes, and sometimes there is red blood cells, can indicate an infection. So usually a bacteria count of more than 100,000 indicates an infection. Small number, if there's only small number of white blood cells with the presence of bacteria, especially if there is epithelial cells as well in the microscopy, then that most probably is a contamination rather than an infection. Usually we treat infections with a short course of antibiotics. Females can be as low as 3 days, so 3 to 5 days, with antibiotics such as trimethoprim, caphylexin, or nitrofurantoin. A patient that has pyelonephritis with loin pain or fever would probably need an admission with IV antibiotics. And sometimes we need to make imaging if the patient doesn't improve with the antibiotics to make sure that the patient doesn't have an obstruction or pyelonephrosis, which means pus collecting into the collecting system that might need drainage. So that was our question before. Can you blame the hematuria and the combination of the UTI and warfarin treatment? Does the patient need further investigation? So two important questions. the patient had a UTI, which was proven by his dipstick with the nitrate, leukocytes, and his symptoms. However, he had a hematuria, and let's remember that he had an episode of hematuria previously without any other symptoms. So can we just say that it's because he's taking this blood thinner, and just because he's having infections, that's the cause of his hematuria, and just ignore it? Or does he need further investigations? Okay, so again, let's try to answer this question on Menti. So if you go to www.menti.com and try to use the code, and let's see if it works this time.
Okay, so I'm getting some messages that it's working now. There we go.
Okay, good. I'll give you 1 or 2 more minutes to see. What do you think, guys? Okay, that's very kind of close. It's almost 50%. So okay, so 42 for yes. We can just blame the warfarin and the UTI, while 23 is saying no, we need further investigations. Okay, so numbers are increasing, so let's just give it a few seconds. Okay, 43 to 25. So the fact that the patient is on a blood thinner doesn't mean that we can actually say that this blood thinner is causing the hematuria, the blood in the urine. So think of it as a normal physiology. So why would anyone have blood in the urine if they're not having an underlying problem, even if they're on blood thinners? Would someone bleed out of their skin just because they're taking blood thinner? They shouldn't. Injection sites ecchymosis is something different. But yeah, if someone is taking blood thinner, it can make the bleeding worse, but it shouldn't cause bleeding on its own. So hematuria cannot be blamed on the warfarin or any other blood thinner. If the patient has hematuria and he's on a blood thinner, he still needs to be investigated, just like any other person. So that's very important to know. And this is a very clear message. He needs further investigations, okay? Yes, UTI can be partially blamed for hematuria in young females with an infection, yes, but on other people, it needs to be investigated, okay? So make sure that each time you see a hematuria patient that you do refer him to a urologist for investigation, okay? Make sure that you're conscious about hematuria because it can be an alarming symptom, especially if it's a gross hematuria. And we're going to talk in details about when and how to refer the patients with hematuria into the urologist. So one more point to say, all males with a UTI needs further investigations, not for females. And that's just because females have a tendency, unfortunately, to have infections due to short urethra and other physiological factors and anatomical factors that cause them more infections. However, in males, they shouldn't have an infection. And if they do have an infection, then there is an underlying cause that needs treatment. Okay, I'll go to the next slide. So, does he need to be referred to a urologist? And should this referral be urgent? What do you think the urologist will do for this patient? And what investigation does the GP need to do and would be helpful for the urologist? So a lot of important questions that comes to everyone's mind. So if you're sitting in a GP practice or you see a relative with a gross hematuria, you're going to get asked, oh, so what's next? You want to refer me? And how urgent shall I see my GP or my urologist? And what tests do you think my urologist will do? And what tests shall I take with me to the urologist? So these are very important questions. So again, we'll use Mentimeter here to have a question.
Right, so we're going to start with a countdown. So everyone get ready to answer the question. Oh. You try and click enter on your side.
Yeah, I'm trying, but it's not working.
Okay, there we go.
So would you consider this as an urgent referral to a urologist? Okay, that's great. So most of you would consider it as an urgent referral. That's very good. So yes, it is definitely an urgent referral. So gross hematuria, especially if the patient doesn't have the symptoms of infection, like our patient who had 2 episodes, one with infection and one without, is a very important indicator for possibility of having bladder cancer. So this patient definitely needs more investigating and need an urgent referral. So any male patient aged over 45 with visible hematuria will need UNAs. So we've asked, what should the GP do? So the GP needs to do UNAs, and that's because when the patient reaches the urologist, we'll most probably need a CT urogram, which requires an up-to-date kidney function, a full blood count. Obviously, someone is having a hematuria, then he's bleeding. We need to make sure that the hemoglobin is okay. If we suspect an infection, we'll need to see the inflammatory markers such as the white blood cells. So that's also give us an indication. A PSA test would be very useful because hematuria sometimes can indicate prostate cancer as well. But just to make sure, PSA is only done if we do not suspect an infection, because if there is an infection, PSA is going to be high. As a urologist, what we will do is we will arrange this patient to have a camera inspection of his bladder, which we call flexible cystoscopy. So for a female, we'll go through the opening down below. For a male, we'll go through the urethra, through the penis, and go all the way into the bladder, take a look inside, and make sure whether there is any abnormalities inside of the bladder mucosa. A CT urogram or an ultrasound will be done according to the risk of the patient. So upper tract imaging to make sure that this hematuria is not coming out of the kidney. So as you know, it's just one tract. So blood out of the urethra can be coming from anywhere in the urinary tract. So we still need also to rule out problems within the kidney. So urine cytology, I'm not going to talk about it much because there is a lot of debate regarding it in literature. However, with high grade or high risk cancer patient, it might be useful sometimes to do it, but it's not mandatory to do it for every hematuria patient. Okay, so what about asymptomatic patient aged under 45 with microscopic hematuria? These do not need to be referred to urology. So young people with microscopic hematuria, not gross hematuria, microscopic, okay, they do not need to be referred. So you need to check their GFR, blood pressure, and rule out a nephrological cause of their hematuria, because the probability of him having a cancer in the urinary tract is extremely rare. So all patients with gross hematuria will need a cystoscopy and upper tract imaging, as we've said. So the only people that we might exclude is a young female with a UTI that it has resolved on infection, but we need to make sure that she never had any other episode of hematuria where she didn't have an infection. And if it recurs, then yes, absolutely, we refer her. So all patients aged over 45 should have a cystoscopy and upper tract imaging, as we've said. Patients aged over 45 with gross hematuria are at high risk, and a CT urogram rather than an ultrasound should be done. So gross hematuria for patients over 45, we do a CT urogram. Gross hematuria patients under 45, we do an ultrasound to rule out upper tract pathologies. So these are the national guidelines in regards to how to refer the patients into the urologist. So if you're a GP in practice or you're GP trainee, do I need to refer this patient as a 2-week rule, or do I need to refer him urgently or not? So these are the self-explanatory, nice guidelines. I've mixed it with a bit of Bow's guidance as well, which is the British Association of Urological Surgeons. So if there is a dysuria with unexplained microscopic hematuria for patients aged 60 or above, then 2 weeks referral, which means an urgent referral should be made. So dysuria with microscopic hematuria, but the patient is over 60. Obviously, gross hematuria, visible and unexplained, without an infection, or it persisted after an infection. For patient 45 and above, again, that's an urgent referral. Persistent infections or recurrent urinary tract infection in patients aged 60 and above needs to be referred as well to rule out cancer. But these are not urgent referral. These can be a regular referral, more or less. So any gross hematuria for a patient over 45, basically, it's an urgent referral. And dysuria with microscopic hematuria for patients aged 60 and above. Microscopic hematuria doesn't require an urgent referral, but it does require a referral for the urologist. So just to explain previously, any painless visible hematuria of any age was actually referred as a 2-week referral. However, due to the fact that microscopic hematuria has been found to be very much not indicating a significant pathology in a lot of patients. So we were basically over investigations patients that are less than 45 years old. So these are not urgent anymore, and that's why they've stopped just referring them as urgent referral. So we refer patients over 45 now as on a 2-week wait referral, which is basically the urgent referral. Okay, so you can see here some scans showing patients presented with gross hematuria. So for the 2 upper scans, what do you think the cause is? So if you just go back, give them a second to take a look at the scans. Okay, so there are the 2 scans on the upper bit. So think, what are the causes of the hematuria? Why these patients present with hematuria? Okay, let's go to the next slide and see what do they think. Okay, great. So stone is the right answer. So most of you have found the stones, which is quite impressive. So that's very good. So yes, there are stones. If you look at the picture to the left, there is a urethric stone just at the upper bit. Let me see if I can have a marker there. So yes, laser pointer. Oh, sorry. Can we go back one slide? Just trying to get the pointer. And it's not working greatly, sorry. Okay, So I hope that the pointer is working now. Okay. So this is where I'm pointing on the left image. That's the stone and the left upper ureter there. And again here, if you can see on there is a kidney stone there on the right image there. So it's just a kidney stone. So next question, on the lower scans, what do you think the cause of the hematuria is? So we'll go to the next slide now. Okay. Oh. Sorry about that. Mentimeter is a buggy meter, to be honest. So let's, each time I click Zakaria, can you try to click enter? Each time I click it, it just goes into the next slide.
Yeah, I'm going to give this a shot. Just 2 seconds.
Okay.
There we go.
Okay, great. Okay, that's great. So 41 persons found that it's cancer, and that's the true answer. So I'll try to go back into that slide, and I hope the pointer will work quicker this time. Okay, so if you look at the scan to the left, that's the left kidney, and you can see all of this is actually cancer. So it's necrotic and it looks really ugly. So that's what we call an ugly duck, really. So that's the cancer. While here there is just a small mass on the CT scan to the right. You can see that there is a small mass just right here in the kidney. So that's the mass. And both of these patients have actually presented with gross hematuria. So as you can see, multiple causes: infection, kidney cancer, bladder cancer, and don't forget that Batman get a lot of hematuria due to trauma. So that's a very also important cause of hematuria, which is trauma. Okay, so trying to get to the next slide. So Mentimeter causes a lot of trouble, to be honest. And I'm going to call it from now on buggy meter. Can we just go to the next slide? Okay, great. So our patient, Mr. Adamson, let's go back to him. This nice gentleman, we've given him a course of 5 days of antibiotics of caphylexin. His symptoms improved, and his GP has done the right thing by referring him to us under the 2-week rule. His symptoms are much improved, and as we've said, his flow is still a bit low, but that's not something that is very significant for his age. A urine test at the clinic now shows only blood, but no nitrite, no leukocytes. We do a cystoscopy, and we find 3 small papillary bladder tumors. If you look at the image below, that's a typical appearance of a bladder papillary tumor. And we do a CT urogram, as he's more than 45, and it shows upper normal tract. Okay, so next slide. So you've heard me talking about urgent referral and 2-week referral. I would like to make sure that you know what is a 2-week referral. So how quickly do we need to treat these patients referred under this rule? And what sort of patients are usually referred to us as a urologist under this rule? That's really important things to know. So my next question is going to be on Mentimeter, is how quickly do we need to treat patients referred under this rule? So it's a 2-week rule. I'm sure you've all heard of it, but I want to know that you truly know what does it mean. Okay, I'm just trying to get to the next slide. Okay, let's hope this works. Go back, go back.
Let me just try in 2 seconds. Okay.
I guess you've all seen the answer, but let's see. Well, now we'll see who's paying attention at least.
Can you try and click enter and see if that works? Oh.
I wish we used Kahoot.
Okay.
Sorry about the technical issues, guys. It's my first time to try this Mentimeter, and it didn't work on my computer. Zakaria helped me at the final moments by presenting from his computer. So, okay, it doesn't want to work. Come on. Can you try now, Zakaria? Just if you press one press and then press enter from your side.
Seems to be a recurrent issue. Let's have a look. No. Right, we'll give this one more shot. If not, then we might have to just go on without this question, unfortunately. Okay. Okay.
Sorry, guys, it's not working. Sorry. Anyway, I hope that you all knew that the 2-week referral means that patients need to be treated within 62 days and not 14 days. So the 2 weeks really means that the patient needs to be seen within 14 days, needs to be investigated within 31 days, and they must be treated within 62 days. So although it's called 2 weeks referral, it means that patient needs to be seen within this period of time and not treated without that period of time, because that's quite unrealistic. So 62 days, okay? And we'll go to the next slide. So what we've asked, what patients are usually referred to urology under this rule? And as we've said, patients aged 45 and above with visible hematuria, so gross hematuria patients that are above 45, any patient aged over 60 with microscopic hematuria, any man with a raised PSA or abnormal feeling prostate, so it's suspecting prostate cancer, any man with a testicular mass or possible penile cancer, and any patient that was found to have a kidney lesion. So all of these are usually referred under this rule. So it's basically a cancer referral way to make patients just have a priority, as cancer patients, our treatment is very sensitive, time sensitive. So this rule was made to make sure that these patients get priority to be seen as soon as possible and to be treated within the time limit. And a very important question that I want you to think of, so what we're going to offer this patient as treatment is a TURBT, which means Trans-Urethral Resection of bladder tumor. How far do you think we can wait to do this procedure? Can we wait for the full 62 days or not? So I'll let you think of that until we complete, and we'll come to the answer later on. So why did we repeat as urologists the urine dipstick? And why is the persistence of blood is important? Please go to next slide. Okay, so we repeated this test to make sure that the UTI has resolved, as we cannot do a cystoscopy, even the flexible cystoscopy, which is done in the local anesthetic if there is an infection, because if we do, the patients might get urosepsis, which is a very severe infection. And in contradiction to simple UTIs, urosepsis can be a killer and it can progress very quickly. So urosepsis is one of the most dangerous sepsis that can happen, and they need to be treated fairly early and aggressively. So the absence of nitrite and leukocytes suggests that the antibiotics treatment has been successful, as we've said, and the presence of unexplained red blood cells in a patient over 60 requires investigation. So even if Mr. Abdinson didn't have the cross hematuria episode before, the persistence of this blood in the urine still requires a referral. So we've done the cystoscopy. It showed 3 bladder tumors. What would you tell the patients? What do you think is the appropriate thing to tell him while you're doing the flexi and you're done? You want to sit with him in a quiet place, what you're going to say. What would you do about these tumors? And when would you do it? That's my question previously, so we're going to answer this shortly. What complication do you think would come out of our treatments? And is it important to do upper tract imaging? I believe we've answered this already. And are the tumors likely to be life-threatening? So these are very important questions that all of us get asked about every time we do a hematuria clinic. And the answers are on the next slide. So as I've said, we're going to do a trans-urethral resection of bladder tumor, which means a camera that goes through the urethra into the bladder, and with a heated loop by electricity, we do resect these masses. So it can be done in the general or spinal anesthetic. He needs to stop his blood thinners before the procedure, as we're going to basically be taking a layer out of the bladder and it's going to bleed. So we don't want it to bleed more with a blood thinner. So this procedure needs to be done within 31 days. And if you think of it, it's not, why is that? It's because it's diagnostic. So cystoscopy is a diagnostic as well as it can be therapeutic procedure. So it has to be done within 31 days and not 62 days because it's not just therapeutic. So we diagnose the cancer by scraping these off and sending them to the pathology lab to have a look under the microscope and tell us what sort of cancer are they, or if they are actually benign or inflammatory or cancer. So cystoscopy is a diagnostic procedure, so 31 days is mandatory for us to do the cystoscopy within that time limit. So what are the possible complications of this procedure? Bleeding, of course, as we're taking a layer, as I've said before. Urinary tract infection happens in 1 in 50 to 1 in 100. So it's not very common, but it still can happen. Bladder perforation is rare, so it's about 1 in 1,000. However, it's not really common to happen, but if it happens, it's a serious complication. If it happens, so what we do, how do we treat bladder perforation? If it's retroperitoneal, then we'll just put a catheter for a prolonged period of about 5 to 7 days. However, if an intraperitoneal large perforation happened, then we'll have to do an open surgery to actually repair the bladder. So these patients that have multiple bladder masses or small masses inside of the bladder, after the resection, we do put an intravesical treatment, an intravesical chemotherapy treatment, such as mitomycin or doxorubicin. And the aim of this chemotherapeutic agent inside the bladder is to actually prevent the recurrence of these tumors. So bladder tumors, unfortunately, are the kind of tumors that if one happens, it will probably happen again. So it depends on the grade and the stage of the tumor, whether it's going to happen again or not, but there is unfortunately a high probability that it will actually do happen again. So mitomycin is a treatment that can help prevent this from happening in the future again. There is a stronger treatment called BCG, but I'm not going to talk about it much. It prevents recurrence and progression as well. So bladder cancer can progress in grade as well as stage. So BCG can sometimes help. So why even if we diagnose a bladder tumor, we still need to do an upper tract imaging. So doing a cystoscopy for a patient who presented with gross hematuria, if we do find a bladder tumor, it doesn't mean that we do not need to do an upper tract imaging, because about 5% of people who have bladder masses will actually have also kidney masses. Saying it more appropriately, it's renal pelvis masses. So they are masses in the ureter or in the renal pelvis, so the pelvic calyceal system of the kidney. So transitional carcinoma, once it happens somewhere in the urinary tract, or the urinary tract, or the transitional cell in the urinary tract can be prone to have cancer. So it's important to still do a CT scan, even if we diagnose a bladder cancer for a hematuria patient. It doesn't mean that we found it, that's it. No, we still need to do it. Most of these tumors are diagnosed early, so 70% out of these are actually small tumor that are of a low grade and low stage. And so most of these are treated with only recurrent cystoscopies and TURBTs, and some of them recur, some of them don't. As I've said, intravesical therapy can be helpful to prevent the recurrence and progression. About 60 to 70% are diagnosed early on as a TA or T1, which only requires frequent cystoscopies or cystoscopic surveillance and intravesical treatment, while only 20 to 30% are diagnosed as T2, which would require more severe treatments such as radical cystectomy or radiotherapy with chemotherapy. So most of these are superficial, can be treated with only a TURBT and surveillance later on. So I hope that you've learned some of today's talk about how to manage UTI, investigating hematuria, and the management of superficial bladder cancer. I would like to say again, any patient over 45 with gross hematuria, please urgently refer him to a urologist. So this is the most important thing to really understand from the lecture. Gross hematuria is a very important sign of cancer. So please be aware of it. Any patients that you see with gross hematuria, be sure to assess him well. Do the blood test that we've talked about before referring them to the urologist, and reassure them that they will be taken care of. And if you have any questions, please let me know.
Okay, thank you very much, Ahmed. That was a great presentation, despite all the technical issues. Does anyone have any questions they'd like to pop in the chat box, and I'll relay them to Ahmed just now? Just having a look at the box here. Okay, sorry, I'm just going to need the mouse for a second here. Right, so there's a question here. What would you do for hematuria caused by trauma, if anything?
Okay, so hematuria caused by trauma is a very significant thing to look at. I've not talked about it because it would require me an hour on its own. But any patients that present with gross hematuria after trauma will need a CT urogram. So we will need to do an urgent CT urogram to see and grade the injury. So most of these will depend on what sort of trauma they got. So if it's a loin trauma, if it's trauma going into the loin, then we would suspect a kidney injury. If it's an acceleration, deceleration, it can be the kidney or the ureter. And if it's trauma to the abdomen, then we would suspect bladder injury. If it's a pelvic fracture or trauma to the perineum, then we would expect a urethral injury. So it will depend on the scenario, but the most important thing is to start with a CT urogram for patients with gross hematuria that we suspect kidney or bladder injury. Urethral injury, we usually do a retrograde urethrogram. For bladder injuries, we do cystograms. So each sort of trauma would require a bit of a different sort of management and investigations. But yes, gross hematuria with trauma needs investigations.
Okay, so I hope that answers your question, Enya. And we just have another question from Adele. Why did we use caphylexin for antibiotics?
Well, we've just used it according to the sensitivities of the patients. So he had previous UTIs, which showed that he is sensitive to caphylexin while he was having some resistance to the other antibiotics. It doesn't have to be caphylexin per se with a UTI. I would always advise to go into the micro guide of your trust and use the antibiotics, especially if you're doing an antibiotics up front. Go to the micro guide, go to urinary tract infection, and see what your trust advised. Each trust has its own really guidance in regards to what antibiotics to start with the UTI. And of course, cystitis would have different treatment from pyelonephritis. So yeah, for this specific case, we've just followed the previous sensitivities of the patients.
Okay, perfect. I think we have more time for one more question. So we have a question from Sarah. Would the age rules also apply to ambulance staff too? Would a male under 45 with no clear infection be advised to contact the GP, or would you recommend conveyance to ED?
So, sorry, can you repeat the start of the question?
So would the age rules also apply to ambulance staff too?
What do you mean by ambulance staff? Sorry.
Could you perhaps elaborate on that, Sarah? Sorry. I'll just give her a second to type.
Okay.
And I think her other question was, would a male under 45 with no clear infection be advised to contact the GP, or would you recommend conveying to ED?
Yeah, so if it's a gross hematuria, definitely to contact the GP. If it's a microscopic hematuria, we would usually advise them also to just contact the GP to repeat the urine test in another time. So sometimes what we care about in microscopic hematuria, that is persistent hematuria. So if someone has only microscopic hematuria once, okay, that doesn't mean anything. It can be really anything like dehydration. Sports sometimes can cause microscopic hematuria in a young person. But if it's a persistent hematuria, then yes, by all means, you need to contact your GP so that you can get referral to the nephrologist rather than the urologist to get more investigations. If it's a gross hematuria, then yes, you would be actually referred to a urologist. I hope that answers the question.
Amazing. Okay, thank you very much, Ahmad. That was a really good presentation, and I hope it was useful to all of you. We apologize, obviously, for the technical issues, and to our next slide, obviously, we really appreciate your feedback. So we will be willing to accept any constructive criticism. So feel free to.
A lot of criticism. So I was afraid the whole, all the way through that my daughter would just bump into that door and I will be on YouTube.
Right, so feel free to use the QR code on the slide, and I've also popped the link in the chat box for the feedback form so that you guys can give us some feedback and get your certificates. If you have any other questions, feel free to send us an email at the address that's just there, and be sure to join us next time on clot retention. So thank you very much, everyone, and have a good night.
Thank you, everyone, and have a good night.